Hey everyone, this is Joe Minardi. I'm coming to you live from the WU Emergency Medicine Recording Studios, and I've got something today for you a little different than my usual point-of-care ultrasound content, but hopefully something that's useful to us that work in rural or community emergency departments where we may encounter children and injuries and have to deal with those pretty much on our own without any other assistance from others. And so, with that said, I'm just going to jump right into this. Here's the case. This is an 8-year-old male, fell from the monkey bars, has an obvious forearm deformity, is able to wiggle all the fingers, sensations in tactile touch, vitals are normal, thorough physical exam, and there's no signs of any other injuries. So we'll focus on the main injury in this case here. And you get some x-rays, and this is what you see. So we've got a kind of distal third both bone forearm fracture. It's pretty significantly angulated and displaced. There's no hidden injuries here. There's nothing subtle about this, okay? Now let's just talk about what are we going to do with this. So in many places I work, it's certainly an option to transfer this where they can see pediatric orthopedic specialist and get that kind of care. Obviously, if that was going to be the option here, case would be over, we'd be done. So that's not what we're going to talk about. We're going to talk a little bit more, spend some time talking about option 2, which is what I would advocate should be done and needs to be done in these cases: sedate, reduce, and splint this locally. And I'm just going to go over why, and then give a few little tips and things about the technique and what to do, and why you should take ownership of things like this and not defer them for transfer and other care. So option 1, obviously transfer, and this does happen sometimes, but this leads to delays, contributes to ED crowding at larger centers. And one of the things that sometimes I talk a lot about in my teaching with residents and even with some within our group is you lose some control over the care for the patients that you're providing, and you lose control of your emergency department, and you have to rely on others, which I think is at least somewhat can be a contributor to burnout. So we'll talk about that a little bit more. Then option 2, in my opinion, again, this is mostly opinion, but also I'll make the case that this is well within the bread and butter, meat and potatoes scope of emergency medicine, but it's better for the patients. They don't have to travel sometimes hours away to a referral center. They can often follow up locally, even if you don't have a pediatric orthopedist in your community. Most of the time, if they are non-operative cases, they can generally be followed locally. Biggest thing, and I like to mention, is maintaining autonomy and maintaining as much control over the care for the patients in your purview as possible, and maintaining as much control over your entire emergency department and the flow of your whole department full of patients that you're responsible for. And then, if you're the business person or the medical director, you may care about that retaining these procedures and sedation and things locally is probably better for your revenue and your budget cycle. Not really the focus here. So again, the patient benefits, fewer delays, right? No transfers to hours away, worrying about are they going to be able to get a ride, and then are they going to have follow-up that's also far from home. So these things are things that are on patients' minds and should be on your mind as well. And one thing that maybe isn't always taught, but you'll learn when you work in rural places and communities, is that even your adult orthopedists will follow most non-operative pediatric fractures, assuming it's non-operative, and 2, you're able to get a decent reduction and get it splinted in the emergency department. And that's a benefit for patients. Again, they don't have to travel for follow-up, but again, often not talked about or really widely taught in, not in textbooks or some standard piece of emergency medicine curricula. So worth knowing. And then again, I want to touch on this, and I harp on this some, is that, and this is shown in other job satisfaction literature and employment-based literature, that one of the key factors to job satisfaction and combating burnout in any job, and this goes beyond just emergency medicine or medicine in general, is the sense of control over your own environment, sense of control over your job and your tasks and what you're supposed to do. So just, the easy thing is that autonomy equals job satisfaction. I am a strong advocate of maintaining control and owning as much of the patient care process in the emergency department as possible for a couple of reasons. One is it just makes the job more satisfying and easier to manage when you can maintain control of everything. Every time you call a consult or you transfer a patient or you defer an opinion to someone else, you're giving up a tiny bit of control over the care of that patient with you and giving up control to the overall management of your department. So whenever possible, I strongly advocate that you maintain as much control over the care for the patients that you're responsible for and your department as possible. So the prerequisite is you've got to have adequate knowledge and the requisite skill set to manage as much of this as possible. And obviously you can't control everything. There are things where you're going to have to call, you're going to have to ask for advice, you're going to have to defer, and other people are going to be involved in decisions. But the less of that you do, again, within the scope of emergency medicine in your practice, the more control you'll have over the care of your patients and your department. And trust me, I believe you will have better job satisfaction. So that's my little rant on autonomy and owning as much of the care of emergency patients as you possibly can. Now, let's just move on to some of the things that you can do to own the care of this particular patient in cases like this. Now, obviously, pediatric patients, most of the time we're going to sedate them largely to, even though you could probably do other things, you could do hematomal blocks, you could do regional anesthesia. Part of the sedation is just shielding them from the traumatic experience that they're going through with their injury and, hearing their bones crunch and watching things happen. So sedation is perfectly reasonable. And then, the reduction, if you've not done them a lot, it might seem intimidating. You might think this is outside of your scope, but this is not. We don't require surgical instruments. We don't need a lab tech. We don't need a lot of fancy equipment to do this. Most of this can be achieved with some traction, recreation of the injury mechanism, maybe exaggerated to some point, and then some exaggerative corrective movements. And then I'll go over a little bit how you can monitor the reduction with some of the tools that might be available or might not, such as the mini C-arm, which is available in some places, maybe not everywhere. However, point-of-care ultrasound is pretty much available everywhere, so I'll go a little bit over how you can identify fractures and monitor reductions using point-of-care ultrasound as well. So the first thing, and usually you're going to need an assistant to help you. So this is pretty much always about a 3-person operation because you have your nurse that's documenting and kind of overall looking at vital signs and assisting with the sedation process. Often you need another assistant to help you just maintain some traction, counter traction on this patient while you do some of the manipulation. So this is the first, and this could be an assistant that's helping you provide traction. That's usually how I do it. And then the next steps, here's a video, and this is from a great YouTube channel called @OrthoFilms. A quick little animation. This is of a distal radius. So in this instance, we're showing traction here. You may apply pressure to the fracture fragment. That's often inadequate, so then we'll exaggerate the injury and then try to align the bone in place. Now, one thing that's not really shown here is then sometimes exaggerating the corrective mechanism forward, which you may sometimes need to do. But that's the basics of this. Again, a distal radius. I go over that because these are common, and our case is a little bit different. In this case, this is more of a distal third both bone forearm fracture, and most of this can be resolved largely with traction, although you may require some recreation of injury and then some exaggerated corrective motion as well. So here, this is the pre-reduction images. This is what they look like, and that's what we did in this case. After sedation, one assistant helps with traction, and then manipulation with recreation of the injury, traction, and then some exaggerated corrective motion and to look at the alignment. Now again, we talked about evaluating the reduction. Not everybody has this, but if you do have it, and sometimes you have to ask, does somebody have one of these in the operating room of our hospital? And they may have it, and it's not widely known, or it doesn't sit in your emergency department. But these are more available than you probably realize that they are. And I like these. They're useful, especially once the splint is on, because you can't really do point-of-care ultrasound through the splint. But if you want to look at your reduction after the splint is on and make modifications in your mold, these are nice for that. Obviously a luxury. If you don't always have it, it's not going to be there. But next, let's talk about using point-of-care ultrasound. So if you have your ultrasound in the department, you can just look at the fracture. You're going to look at lateral edges and dorsal and maybe volar edges of the fracture fragment to look for alignment. So this is just a quick demonstration of what that might look like here. And what I like to show folks is doing the lateral ultrasound, here is on the radial side, is kind of equivalent to looking at the alignment of an AP x-ray. So just imagine how that beam goes through your bones and what alignment of fracture fragments you're looking for. And then here, this is just showing, we've got, this is radius, this is the distal fragment, and you can see they're significantly malaligned. And then probably one of the most useful images is this. So it's a dorsally located ultrasound on the distal radius fragment, and that is what gives us kind of the equivalent of our lateral x-rays. Now you could also do an anterior or a volar view to look at the fragment from this angle. That's certainly reasonable. But this is what we're looking for, and I'll show an example. In this case, this is a dorsal ultrasound, and this shows us alignment such as we might see it in a lateral x-ray. We can see radius fracture fragment that are significantly not lined up. And what we will hope to do with our reduction is get those where they look more straight. And you could also, if this is an adult and you're doing a hematoma block rather than a sedation, you could also guide your needle in plane into this fracture site to get you what I think is probably going to be a more effective hematoma block. And just as a quick demonstration, here's a little video of one that's from my YouTube. In this one, we've got the distal fragment aligned on this edge of the screen. So this is the proximal piece of the radius, and we'll just show, and I'll kind of zip through this a little bit. So here's where we do, that's the fracture site, hematoma block. Again, this would be if say you're not doing sedation, and then the goal, and this is what I want to show you. So looking during the reduction, so it's not lined up adequately, we kind of do some more manipulation, and then hopefully we can get something that looks more like this, where we see the bones are much better aligned, more satisfactory looking. So that's what we're looking for with ultrasound. And again, point-of-care ultrasound, pretty universally available. So if you don't have a mini C-arm, which you're not going to have everywhere you go, ultrasound can be used at least during the reduction process. Now, a few just little tips about this splint. Again, if you haven't done these a bunch, all these little tiny things that really aren't that big of a deal, they seem a little intimidating. So I'd just like to go over them real quickly. So what I like to do is I wrap them generously in soft roll from their MCPs to their distal humerus, and then I'm going to show you just a few little tips. Pretty much every emergency department on earth has those stacks of ortho glass everywhere, so I'll show you what I like to do with that. So here's just an example. It's wrapped generously with soft roll. Okay, for both bone forearm fractures and distal radius fractures, we're going to be using a sugar tong type splint. So wraps around the elbow, comes up just past the thumb, and I'll go over that in more detail, and then should come up to roughly the MCPs on the dorsal part of the hand. And what I like to do is I figure out the size of ortho glass I need, the length that I want, size, the width and the length, and then I strip it out of that soft cover that it's got, because I've already wrapped their arm in soft roll to get the desired effect that I want for my splint. So I take out, so I just have kind of bare fiberglass, a big long rectangle of fiberglass, and then just a couple little things. You're going to make a little groove for their thumb, so you just cut that out and shape it. I also just trim off any kind of sharp edges that might be irritating to their skin so that they don't have problems with it later. And another thing is, once you figure out you've shaped it and you've figured out where the bend of their elbow is going to land, cut a little couple of triangles into the splint, the fiberglass at that point, to help it, again, just shape better. It'll be more comfortable and be an easier splint for the patient to manage later on. So you get it on, you shape it. An important point is that it needs to come up just barely past their thumb. Their fingers, they need to be able to flex at their MCPs all the way down so that they don't end up with stiffness in their fingers. Again, most of these are going to follow up and probably be converted to a cast pretty soon, but you still want to do this right and do a good job with it. So these details, little details, make a difference. And then your mold, once the splint is in place for a both bone forearm fracture, this type of mold, the interosseous mold, is most important to maintain the interosseous space between the radius and the ulna. So that's probably your most important mold component for the both bone forearm fracture that we have in this case. Sometimes you may apply a 3-point mold as well. This is more commonly the type of mold you want to do with your distal radius fractures. So you see, highlight here, the 3 points. So we've got the knee on the back of the elbow. Now got a hand kind of right at the fracture site, or very close to the fracture site, and then we're applying some pressure. Typically we like to have them a little bit flexed and ulnar deviated if possible. My one little quibble with this is, you'll notice this elbow needs to be at a better 90-degree angle. So if I see you splint like this as one of my trainees, I will yell at you and complain. Their elbow needs to be at a very firm 90-degree bend when you place the splint. So in this case, this is what happened here. So we sedated, reduced with the methods we already kind of talked about. These are our post-reduction images in the splint. These are satisfactory, and that's pretty much the case. And cases like this, again, even though it's a pediatric case, most adult orthopedists are willing to see this in their office and put them in a cast and follow them, again, because it's a non-operative case and you're able to achieve a decent reduction. Probably always still worth a phone call and assure that your local adult orthopedist is willing to see and follow this, but most of the time they are. And again, that's good for the patients. They don't have to travel, they don't have long follow-up distances and transport problems and things like that. So the main points: pediatric Pediatric forearm and wrist fractures are a core component and are well within the scope of emergency medicine. Don't let anyone tell you that it's not. Local care is better for patients, and I hope that I kind of made that case to you. And then don't forget the whole idea of maintaining autonomy and control of the care for the patients that you're responsible for, and the care of the overall flow of your department and the patients, your whole group of patients that are in your department at all times, and how that maintaining as much autonomy as possible gives you a better work experience and a better work environment, and hopefully decreases your risks of burnout. So that's pretty much the main teaching points that I have for you. But wait, there's one more thing. So a little bonus teaching point here. This case was an open fracture. So there's a little pinpoint hole. We see it here. This is just some dried blood from that fracture. So this is an open fracture. Now, it was kind of news to me the first I learned about this, because I always taught, open fractures go to the operating room, right? It's pretty much an automatic thing that we think about with open fractures. I mean, sometimes in the hand, distal parts of the foot, we have some exceptions, but for the most part, open fractures equal operating room is kind of our standard teaching. But there is some evidence, and this is actually the practice of our local pediatric orthopedists. Type 1 open fractures. So this is generally kind of a pinhole, right? A small little hole that's relatively clean, right? They weren't playing in horse manure or something like that. So type 1 pinhole open fractures in pediatric patients, and this was mostly forearms and distal radius fractures in these studies, can be treated non-operatively. You give them antibiotics in the department, you put them on antibiotics for say a week, and they have equal outcomes. You should definitely irrigate that wound as well. So those are the keys. The bonus teaching point here: select type 1, meaning kind of pinhole open fractures in pediatric patients, can be treated with just irrigation, antibiotics, reduce, splint, and don't need to be treated in the operating room. The one caveat is this is one, if it's an open fracture, I would always have a phone discussion with your orthopedist or even your pediatric, whatever referral center pediatric orthopedist is around, at least your local orthopedist for sure. So that's it. That's all the teaching points I've got for you. Hope it was helpful, and I'll see you in the next one. Thanks.